Thank you, Dan. And I want to reiterate what Sue said. It truly is an honor for us to be here and representing PCNA and helping you with this. I'm going to turn to the side just a little so I can see the slides. So as has previously been mentioned, 1.8 million Americans currently experience thromboembolic illnesses, 75,000 of whom have atrial fibrillation, 900,000 with venous thromboembolism, and close to 800,000 with stroke. And as Sue mentioned, 2 million die from thrombosis each year in one form or another. Of the survivors, many of these people frequent hospitals, offices, outpatient clinics, and emergency departments for follow-up care and recurrent problems that happen, all in varying degrees of disability. Let's talk a minute about atrial fibrillation. This is a very common abnormal heart rhythm that occurs in the atrium of the top of the heart. Let's see if I can get that too. In this area, generally there's one focus that contracts in the atrium that creates the heart rhythm. With atrial fib, there can be literally 100 little fireflies going off in the atrium, so it's a very irregular pattern, and also the atrium loses some of its contractile force. It's during that time, the irregularity and the weakening of the contraction, where a clot can form. And this is what the EKG looks like. That's a normal pattern and what the abnormal rhythm looks like. 2.6 million Americans have atrial fibrillation, and it's estimated that 1% of the population will acquire it in time. The lifetime risk is 1 in 4 people from age 40 on that will develop AFib. And this is a graph to show the relationship between age and sex, and clearly you can see that it increases as we get older, and that's where the Medicare connection has come in as well. It appears on this graph that men are at higher risk of developing AFib than women generally. And this is another picture of it looking in 5-year increments and the estimate of the frequency of atrial fib occurring. We are currently at the 2.66 million Americans, and just within the next decade there'll be a 21% increase, and then the decade following that a 25% increase, and then the increment diminishes somewhat simply because all of us in the baby boom generation are passing along at later stages here, but that's where the crux of this is happening. The greatest hospitalization from complications of atrial fib is with heart failure, and following that is coronary heart disease or coronary artery disease and stroke. For patients who are not treated with anticoagulation, and some patients don't have symptoms actually, or if they do, what we're using currently is something called warfarin that is affected by many, many different things, including diet and other forms of disease and other medications. So there can be varying levels of anticoagulation on these patients. And so even if they're being treated, sometimes they're not responsive and can have a stroke even being on Coumadin. So within the first 4 months of diagnosis, the greatest risk of death is with a diagnosis of coronary artery disease. Heart failure follows that, and ischemic stroke follows that cause of death as well. And then following 4 months of diagnosis, there's a decline with coronary artery disease and, and stroke, but heart failure deaths increase. And this is something that we see frequently in our practice. People going into congestive heart failure when they're in atrial fibrillation. Let's talk about deep vein thrombosis for a moment. This is a blood clot that generally occurs in a large vessel in the lower extremities, but it can also occur in the arms. And the concern with that is that a piece of the clot would break off and travel into the lungs. This can cause sudden death from what's called a pulmonary embolism, or clot in the lung. Each year, over 900,000 patients are either have a new or recurrent deep vein thrombosis occur, or venous thromboembolism. Approximately 200,000 of those are new every year, and 60% of all venous thrombosis occur either in the hospital or in a nursing home with chronic care or postoperatively from surgeries. This is a graph to show, it's very difficult to see, you're not able to see the other increments, but they included all venous thrombosis, pulmonary embolus, and DVT alone. And what you're looking at right here is just the deep vein thrombosis alone. So unfortunately, the screen doesn't show it, but it's a steady rise with age. Again, another disease that is worsened with age. So there's an estimated 300,000 deaths every year from a venous thrombosis. More than 59% of them are from pulmonary emboli. So that's the great complication that we really want to try to avoid. 250,000 patients are hospitalized every year with a venous thrombosis. And some of these have prolonged hospitalizations in the intensive care unit, and just with the venous thrombus, but also with pulmonary embolism. Hip and knee replacement surgery is very common as we get older, and this is one of the areas where we see very high incidence of venous thrombus. They're at great risk of developing that. Again, it's always a balance between anticoagulating someone postoperatively and preventing the clot from forming. But if patients are not treated, then half of them will develop deep vein thrombosis, and even 1 to 2% of them will develop pulmonary emboli. So 200,000 new cases are diagnosed each year. 30% die within the first month, and 20% die from pulmonary embolus. 30% survive, but what you see is recurrent venous thrombosis. These patients never fully resolve from their venous thrombus. Let's look at stroke for a moment. There are two forms. One is ischemic stroke, which we're talking about today, that comes from clot. The other one is hemorrhagic, that's caused from bleeding outside of the artery or vein into the brain. Both of them cause damage to the brain, causing cells to die in the brain. So whatever area is affected is going to have the impact on how the patients respond from that. So 7 million Americans have suffered from a stroke starting from age 20 on. Almost 800,000 Americans are diagnosed with stroke yearly. 3/4 of them, it's the first time they've had a stroke. 25% have had recurrent stroke. This is a graph to show the prevalence, and again, something that we see with age, certainly almost a quarter more, 30% more, when you get into the 80 and beyond age bracket, but it incrementally rises with age. Stroke is the third most common cause of death in the United States. 1 in 18 deaths are caused from stroke, and it's the leading cause of serious disability as well. Of those that survive, 30% have been treated in an outpatient rehabilitation clinic, hospital setting. 15 to 30% are permanently disabled and will either require long-term care in a nursing home or facility or have home care come in. 20% require an institutional care for approximately 3 months after the stroke has occurred. Only 10% recover completely. These patients are left with varying degrees of disability. Some have paralysis of one side or more. Some are left with mild weakness. Others have difficulty speaking that may not completely resolve. They develop depression over time because they're stuck in a sick body that doesn't function. And they oftentimes need assistance just with getting up and getting dressed and bathed in the morning. The mortality rate is the highest again, as we get up into the older bracket, but it's incrementally increased with age. So what can research help for us? What we look at currently, up until this time, we've had warfarin and aspirin to treat atrial fibrillation with. And as I mentioned earlier, there's varying degrees of balance or steady state with warfarin. Many types of things can interfere with that medication. So even if they have their blood tested, which is the only way we can dose them adequately, they may be therapeutic in their blood at the time of the blood test, and they could change within 24 to 36 hours, being either too thick or too thin. So there are many variations with warfarin. Recently, there's a new class of medication called direct thrombin inhibitors that have been released. There's one on the market right now that we're able to use. That affords a steady state of anticoagulation in patients and does not require blood testing. So this is something that we're really excited about, and hopefully there'll be others that are on the pipeline that will come out and help us with that. And they're currently indicated for atrial fibrillation and also to prevent deep vein thrombosis in post-op, primarily orthopedic patients. For stroke prevention and treatment, there are new investigations that are going on to protect the nerve growth and also cells that have been damaged in the brain. They're using hyperbaric oxygen to try to recover some of these cells that have been damaged. There can be stunning of tissue surrounding the death of tissue as well, and you want to try to bring some of that back. Dropping the temperature, the body temperature, is also being evaluated to see if that can help survival with brain tissue, and also stem cells are being investigated as well. There are new, more advanced imaging techniques that are being evaluated for MRI and intravascular sonogram so that they can specifically look at where the clot has occurred and also surrounding tissue that may have been damaged. So we all practice medicine based on evidence, and it's based on research. That's how the guidelines are written. That's how we all practice. And we can't move forward without more funding for research. Medicine will stay stagnant and will be limited to the medications and the treatments that we have at this time. Sometimes we look at only the short-term goals and the cost of doing research, and it just seems astronomical. But when we look at the long-term and the big picture, it is well worth the investment that we have to make in order to hopefully eradicate some of these diseases, but definitely treat in better and shorter terms. Thank you so much for your attention.